together. Here we go. Okay, are you guys seeing the first slide about best practice for expressing, storing, and handling human milk?
It looks good, Claire.
Okay, hopefully I've got the sound going too. Today we are going to be discussing and doing a little dive into this new edition of the best practice for expressing, storing, and handling human milk in hospitals, homes, and childcare settings from the Human Milk Banking Association of North America. It's a really important reference book for all hospitals that have perinatal services to have on hand. And I'm really pleased to tell you how fortunate we are to hear from the editors of this newly released 5th edition of Expressing, Storing, and Handling Human Milk. They are both traveling to a conference today, so they agreed to a short recording in which they're going to introduce this important resource. So first, I'll tell you about Becky Mantle, who's who I want to be when I grow up. She's worked in lactation for over 30 years. She developed and then managed the hospital-wide lactation service at Oklahoma University Medical Center for 15 years. She's currently the director of the Oklahoma Breastfeeding Resource Center in the Department of Obstetrics and Gynecology at OU Health Science Center. And she's executive director for the Oklahoma Mother's Milk Bank. She leads the Becoming Baby Friendly project in Oklahoma, which is sponsored by the Oklahoma State Department of Health. She also developed and oversees the Oklahoma Breastfeeding Hotline, provides professional training and education to Oklahoma hospitals to improve breastfeeding care and outcomes. She served fairly recently, 2021 to 2022, as the president of the Human Milk Banking Association of North America, or HMBANA Board of Directors. And she's also the past chair of the International Board of Lactation Consultant Examiners, the past president of the International Lactation Consultants Association, and a founding board member of the National Lactation Consultant Alliance. Dr. Sarah Taylor, who some of you have met. She has spoken here in Georgia before. She's the chief of neonatal perinatal medicine and a professor of pediatrics at the Yale School of Medicine. She directs the Yale Neonatal Clinical Research, she directs Yale Neonatal Clinical Research and leads the Yale Neonatal Nourish team, which specializes in health outcomes research related to maternal and infant nutrition. In addition to her research, Sarah is an advocate for mother and infant nutrition, including equitable access to donor human milk. In 2013, Sarah led the South Carolina Neonatal Perinatal Medicine Collaborative's initiative to provide donor human milk as an available supplement to mother's milk for all hospitalized very low birth weight infants in the state of South Carolina. And to achieve this, she established a Mother's Milk Bank of South Carolina in 2015. She now serves as the medical advisory on the medical advisory board for the Mother's Milk Bank Northeast. So I wanted to make sure you knew who these editors were and why they were chosen to review this book. And now we have a video from them about the book. So let me make sure I'm playing this with sound. Are you all hearing it?
Not yet.
Okay, hold on. Let me make it so that we're hearing the sound. I apologize. There was a way to play sound, and now I can't remember what it is.
Although you might need to go forward in your slides.
What slide are you seeing?
The first one.
Oh, you're not seeing Becky and Sarah Taylor now?
Not yet.
What I'm seeing and what you guys are seeing is not the same.
You have to love Teams. It keeps us on our
Summer is,
toes.
coming to help me.
Okay.
I thought we had it all situated.
Okay.
I'm going to stop sharing and we're going to try again. press share, and then include sound. And then I'm going to choose the right window. Here, it's not one of the windows because I have too many other windows. Oh, it looks like it goes. All right, we got it now. I think we're all set. Hold on, let me get this as one of the windows. I just don't know how to make it come to the top of my windows. Other than just closing out this. It's weird that it was showing before.
Hey Claire, when instead of showing your screen, you can go up to share and then scroll all the way down to browse, and you
Okay,
can open it
I think we got it. All right,
That's how you started last time, and then you
right.
had to, yeah.
All right. Well, hello,
Can you hear it
and
now?
thank you for that introduction, and thank you for
Can, but you're
inviting
not
Dr.
full
Taylor
screen.
and myself to be here today to talk about a project that is near and dear to our heart. And thank you, COVID, for delaying this by at least a year. But we are excited to be here to talk about the Havana Best Practice book. And
Oh, that stopped it though. All right, can you see the full screen now?
Yes.
Okay.
Now now we can see their faces. Okay, now you're on the third one.
Just now I don't have
right. Well, hello, and thank you for that introduction, and thank you for inviting Dr. Taylor and myself to be here today to talk about a project that is near and dear to our heart. And thank you, COVID, for delaying this by at least a year. But we are excited to be here to talk about the Havana Best Practice book. And one of the first challenges we encountered was just addressing language and how to be use gender inclusive language throughout the book, but also not diminish or exclude, breastfeeding mothers, breastfeeding women. So we're trying to make sure that, we're inclusive of everyone, regardless of how they identify. And then also, if we reference literature, of course, we have to use terminology that was used in that particular publication, which to date, most of it has been on either pregnant women, breastfeeding mothers, and so forth. Next slide, please. So some of the changes that we made, and anyone who has had previous editions of this book will see that this one looks quite a bit different, smaller in size. And a lot of that had to do with really just changing the layout and the formatting of the book. And so we went to chapter format, which many of you certainly are familiar with in other textbooks. We recruited chapter authors with a wide range of subject matter expertise. So we really wanted to have the subject matter experts covering, key chapters. And then we added sections in each chapter, such as key points and key definitions, quality of evidence that Dr. Taylor is going to talk about. And then, where is research needed? And you'll hear us talk about that a lot today. We've updated the references, and then new content. We have a section on antenatal milk expression in chapter 4. We have a whole separate chapter on human milk composition, going into a great deal more detail. And then optimal lactation support in the NICU and bereaved milk donors, which is in chapter 1. Next slide, please. Well, we also were just as we can thank COVID for delaying things, but that also allowed us then to include some, really hot off the press new research studies. So we were very excited to get some of those in there. But we also, once again, identified a lot of areas for further research. But we also maintained sections that we knew were extremely popular, such as the human milk feeding errors, appendices, and all the content around that, and handouts and forms and things that hospitals can print out. We included a new one on parental education on donor milk, because we were getting a lot of questions and want to make sure hospitals have a handy tool for providing that education about what donor milk is and where it comes from. And then we made sure that all of our chapter authors and reviewers are thoroughly acknowledged, because they were all volunteer, and we very much appreciated the time that they invested on this project. Next slide, please. So, utilizing the book, the first question is, why this book? This book is now in its 5th edition. Dr. Taylor and I were the handoff team from the previous authors, editors, and many, many thanks for close to 2 decades of work by Frances Jones and Mary Rose Tully, who Mary Rose Tully is no longer with us, but they did a huge amount of work in putting this book together. So, and the reason for that was, as more awareness was growing about the use of donor milk from nonprofit milk banks, and more milk banks were opening, we were getting bombarded with questions from hospitals, healthcare providers about handling human milk, and how do I do this, and how do we thaw this, and how long is it good for, and all of that. And so the band decided, let's put a book together. And here we are in a 5th edition, almost 20 years later. So this is designed to, it can really be used by anybody that has, hands-on human milk in whatever setting, but particularly, hospital NICUs, hospital mother-baby units, healthcare providers, WIC clinics, and childcare centers, anyone that's doing a lot of regular handling of human milk. We want them to have the most current, up-to-date, evidence-based, as much as we have that, on the best practice, so they know the milk that is getting fed to any given baby is safe for that baby. Next slide, please. So these are just quick run through. There's 8 chapters in the book. The first one co-authored by Dr. Taylor and myself, supporting breastfeeding. And we won't have donor milk if we don't have breastfeeding families. And we really would like to see a lot more support for especially NICU families. So you'll have a section in there about optimal lactation care in the NICU setting. And more information, new area on bereaved donors as well. So next slide, please. Human milk options. What are the different types of human milk that may be fed to a baby, expressed milk, donor milk, and things that we might add to the milk. Next slide, please. Human milk composition is an entirely new section, a whole chapter just on that, the breakdown of micro and macronutrients, vitamins, and minerals that are found in human milk. Next slide, please. And then expressing human milk, not only talking about hand expression, but now a new section on antenatal milk expression, and then pump technology and use of mechanical pumps for milk expression, and what are some of the challenges encountered with mothers who are doing a lot of pumping. Storing human milk. This is a chapter we get a lot of questions about, and Dr. Taylor will speak on that a bit more as well. Next slide, please. Transporting human milk, and then a section on emergency preparedness. And I can see going forward that, we may need even, to expand upon that section even more as we, try to raise more awareness about breastfeeding and handling human milk in, emergencies and natural disasters. Next slide, please. Of course, handling human milk in the NICU setting, and safety. And the next one, the final chapter, is one that Dr. Taylor co-authored about feeding of human milk in the hospital setting too. So lots of questions around that as well. And I am now going to turn it over to Dr. Taylor, and you can certainly expound upon any of the chapters that I skipped over too fast. But, oh, and yes, FAQs. Do you want to speak to that? Or I'll do that one. So.
Yeah, I'll go right ahead, Becky.
So as I said, a lot of the questions that, we've received that kind of prompted the book in the beginning, really have to do with milk handling. How long is it good when it's frozen, and where in the freezer do we store it? Or what about if it's been in the refrigerator, and how long, once it's been thawed, and what's the difference between thawed donor milk and thawed expressed mother's milk? So lots of questions that we were getting about that. But, of course, questions that we hope to address with every chapter in the book. So next slide, please. And I will turn it over to Dr. Taylor.
Great, thank you. So thanks for the opportunity to speak with you all. Continuing from where Becky has left off, really highlighting that we looked at qualities of evidence. This was new for the book. And we, I think overall, we're sad that there's so much lacking in quality of evidence when it comes to human milk safety and quality and storage and handling instructions. Definitely were some studies that had a good level of evidence, but overall they were usually poor or no evidence at all. Now I want to clarify, when we talk about the evidence being poor, it doesn't mean that the recommendation is poor. Experience is really, really important in lactation, but recognizing that experience is just that. And when studies are done, then potentially they might show something a little different than the experience. And we need to acknowledge that, change recommendations based on evidence that's being published, studies being done, what's available to us. And hopefully, in the future, as we do more and more of these books, Becky, I don't know that we're ready for that anytime soon, but love to see the level of evidence go higher and higher with more studies and having good evidence behind our recommendations. Next slide. So this is the chart that we get the absolute most questions about. This is the chart that we spent hours on. So the original authors did a fantastic job, but Becky and I really, really wanted to get to the bottom of what had been studied in regard to human milk storage. And what we found as we did that is there's wonderful CDC guidelines, AAP, ABM, the Academy of Breastfeeding Medicine, the Academy of Nutrition and Dietetics, fantastic guidelines, but often they referenced each other, and you would find this kind of circular referencing where there was not a single primary research study that was referred to, and instead the CDC referenced best practice, who referenced the ABM, who had actually referenced the CDC in a previous version. And so it's this big circle. So what we did here, and it may be a little confusing, but not if you understand what our goal was here, is if there is not evidence, we say that, and we say this is expert opinion. Again, expert opinion is really wonderful, but it's important to know when something is expert opinion versus when something's been studied. And I will say overall, as things are studied, that we actually see liberalization and expansion of a lot of these guidelines. So expert opinion is we're so focused on safety, and we can be quite limited and conservative. And as we study these things, we're realizing, oh, milk can stay longer in the refrigerator and so on. So I think a big one we get questions on is the pasteurized donor human milk there at the bottom can be refrigerated for up to 96 hours. This is huge. This really changes things for hospitals. You should not be throwing out donor milk ever. You should be able to use every drop of it. And it really helps to be able to keep it in the refrigerator for up to 96 hours. And this is based on a beautiful study that was done at one of the milk banks in Texas. So great that we are having this evidence, and important then to expand what we can do regarding storage and handling. Next slide. So just again, to emphasize the attention to evidence and where we are in human milk science. So there is so little research that's been done in human milk. really appalling and embarrassing when you think about how much is done in other areas of healthcare. The great thing is we have so many people now going into this area doing phenomenal work. So this is going to just continue to increase exponentially, but it's a problem even in 2024. It's so important for us to study all of the recommendations that we give in the book and to make sure there is research behind them, because as mentioned, more often than not, when we study it, we realize we actually can be more liberal in at least in the storage guidelines. And so we need to do that to protect every drop. There's just, we need to have practices where no milk is thrown away because it's expired, because it was left at room temperature for too long, and so on. We need to know what we're doing with that and have the best practices to salvage every drop of milk, be it mom's or donor milk. And then one thing that was asked of me, and it has been asked, is, why is the research in human milk so limited? And part of it is that there are external interests that do impact this field of research. And so if you go on to the next slide, there is a beautiful review. This is published in the Lancet in 2023. This is focused on lactation support worldwide and all the different factors and context and stakeholders in promoting lactation worldwide, but it also fits for the science of human milk. And so many of you in the room might, really not know that much about human milk science or spend a lot of time thinking about human milk science, yet you're in the room because you're involved in maternal child health care. And sure, lactation is something that's natural, that is, just you would think, oh, everyone can naturally do this, but it just doesn't work that way. We have to have support systems, and we have to have research as to how to best support these families and to nourish babies. And so if you look at all especially there on the right, the actors with collective or competing interest, you have the families, you have government and their agencies, so many different organizations. And then you have corporations and lobbying groups, and you do have the commercial formula industry who is a part of this as well. So just, the fact that this was explained in the Lancet in 2023 means we're making great strides to normalize and invest in and really take human milk science to the level where it needs to be. Next slide. And so Becky and I thank you. We thank you so much for having this conference and for talking about the best practice book. We appreciate all of you and what you're doing with your attention to human milk safety. Incredibly important, that the hygiene around human milk practices and such. We thank you for promoting human milk to be available for each infant, be it their parents' own milk or donor milk, and working to make sure that what a family wants, a family's intention for feeding is what their infant receives. And so this picture on the right side, I go back to it so much. It's just love it. Such a example of where we are in our definition of normal feeding. Normal feeding can look so many different ways. We do see that the benefit of human milk, but there's so many different ways for us to get human milk to each infant. And that's what we're all here to do, is to help each family achieve their feeding goal and to give them the best practices for doing that. Thank you all so much. Have a great conference.
Thank you.
Okay, I'm glad we got that rolling, and now I need to find where I am to get to the right slide to carry on. Okay, I think I'm managing. All right, are you guys seeing the thank you slide?
I think it needs a full screen view, Claire.
Oh, it's the full
Yeah.
screen again.
Yeah, it's full screen again.
Well, we might just have to deal with that because I don't really know how to fix getting to what I see and what you guys see being the same thing. Let me try one other thing. I think it's like my computer thinks that I have multiple screens going is what's happening. Let me get here if I can have it. View. Show. Anyway, we'll just carry on. I'm gonna make it so I'm gonna minimize this so you're gonna see a lot of my screen, see it bigger.
Would you rather I use my screen?
If you want to pull up the PDF, will it play the PDF?
I can certainly try.
Well, you know what? Let me just see if I can make it go again. Slideshow. From current slide. Okay, now I think it'll work. Now are you seeing the just the thank you slide?
Perfect. Yep.
Okay. So big thanks to Becky Mantle and Sarah Taylor for taking time to share some of the impetus for this important reference book and some history and some ways that you can use it. I'm going to expand a little bit on that. Is there anyone who had never heard of this book before that is willing to raise your hand? I'm interested to know if this is, sometimes my perspective is lactation land. So if this was new to you, I hope that you're learning, or maybe you've heard of the reference, or owned different versions, previous editions of the book. I'm also curious if there's anyone who's purchased a new copy, the 5th edition already, if you want to chat or unmute. And then also if anyone wants to share anything they learned from that brief presentation. Anyone? I'm not able to see the chat right now, so feel free to jump in if you
There's not any chat yet, but I
Okay.
think they were on point about saying that they're probably going to need to increase the portion about natural disasters. That certainly seems apt for the times. So
that really stood out to me as well, because that it came out kind of, we've had to look at that really carefully recently with Helene, especially. And then the ABM, since this edition was published, the Academy of Breastfeeding Medicine has published a big, comprehensive document on infant feeding and disasters. So the challenge I'm having right now is I don't know what slide you're seeing. Are you seeing the slide with the two books?
I'm seeing the summary of human milk storage
Okay, let me go back
recommendations.
one. How about
Yeah,
now?
there you go. Yep.
Okay.
You're good.
So this is I kind of put side by side the two kind of perinatal reference books we recommend to any hospital that has perinatal services, either a mother baby, labor delivery mother baby, or a NICU. And these books are great to guide your policy and practice. These are the current editions that you're looking at. If the versions that you have look different, you might want to update to the 5th edition of the Hembana book on the left and the 3rd edition of the Academy of Nutrition and Dietetics Infant and Pediatric Feedings book. These are both books that are helpful in reference, to look up things, but also to, guide your policy and practice. Okay. So I kind of wanted to pull out, Dr. Taylor and Becky spent some time on this chart. This is just the top half. On the right, you see the whole document, and over here on the left is just the top half that refers to freshly expressed human milk. And I kind of wanted to see what you all think about. I was really happy to see these ideal, optimal, and acceptable categories, because as they mentioned, it's not really always cut and dried. I remember I've been doing this kind of work a long time, and I remember just being frustrated helping parents look up, when somebody would call me or contact me and say, is it safe to feed milk that was, I expressed it at this time and I put it in the fridge at this time and it went in the freezer this time and we thawed it and it was out for this long and then we forgot about it. Now is it okay? And I was just like, there's so many different like permutations there that it can get complicated. So I really liked the ideal, optimal, and acceptable categories, but I know that that also has implications when writing a policy. So I highlighted the optimal category for this, which is, optimal that freshly expressed milk is used, it kept at room temperature for less than 4 hours or fewer than 4 hours and kept in the refrigerator for fewer than 48 hours, which is 2 days. And that it's optimal to use frozen, freshly expressed milk that was frozen within 3 months, but also that it's acceptable for up to 12 months. And actually, like, we really have very little research about whether, what happens to milk that's stored for the long term. And some of that research that I've reviewed depends on how cold the freezer was. So I thought maybe it'd be something to look at and consider those kind of few citations there are and those circular references that we've seen before. The acceptability of frozen milk and considering what your guidelines are in your policy and practice to avoid unnecessarily discarding of milk. I know that some systems have dealt with that by just not having an expiration date for frozen milk because we anticipate that it's not going to be used later than 12 months, like in an inpatient setting. But then it's come up before that like somebody had milk. I was contacted by a neonatologist one time about milk that a mother had that was frozen from her previous child that she wanted to use to supplement if medical supplementation, if there was a medical necessity for supplementation for her healthy term baby. And so that was an interesting discussion point because was there a reason to believe that it would be dangerous? Like there isn't any evidence of that. It's not as optimal as her freshly expressed colostrum would be, but if that wasn't available, the discussion was, is that a reasonable thing to offer, to accommodate a maternal desire or family choice to use express milk that had been frozen for longer than 12 months to supplement their own baby. Okay, I'm hoping you're seeing the second slide about storage. So this is the second portion. I appreciated that they pointed out the expert opinion and, for example, completely thawed, previously frozen milk being good for up to 2 days in the refrigerator. They cite Parker et al. And Meg Parker is a very accepted expert, has spoken at our meeting before. So I appreciate that they have citations where they have some to offer here. I'm wondering how these might compare to your policies and if anyone has thoughts on whether it's worth kind of re-examining your policies. Also, I think it's important that everyone who's in leadership knows how often your policies are being reviewed and what citations are in your current policies. Also curious, since we have both mother-baby units and NICUs participating in optimizing nutrition, whether your policies on handling milk apply to all units in your hospital. That could also include other units where lactating people are admitted, say somebody, who's readmitted postpartum, or even someone who has a 10-month-old that's that's admitted to your hospital who is lactating. Does your policy around expressing, storing, and handling human milk apply to everybody, or do you have to have separate sections or separate policies? I'd like to think that's probably not ideal, but I think it probably depends on the institution. In addition to this helpful chart, go ahead. Is somebody?
Sorry. Yeah. Dr. Patel, go ahead.
Yeah.
Yeah, just a question about the pasteurized donor human milk up to 12 months. I think Humana allows 9 month, frozen milk to be donated that's been stored for 9 months, and then it gets processed and sent to centers. Do you have a sense of, there's been some discussion about whether that might be too long or not, and a sense of kind of how hospitals hold on to the inventory, or whether they should use the kind of use the milk that's most likely to expire first, or kind of guidance for hospitals that might be using pasteurized donor human milk in terms of when they look at the expiration date, should they sort it to making sure that they're using the ones closest expiration first, or just how they handle that?
I think that's a great question. That was one of my follow-up questions after watching the recording. I felt like there could have been a whole chart just on pasteurized donor human milk, because you'll see it doesn't reference that this is thawed, like at the room temperature 2 hours. I'm presuming they mean thawed pasteurized donor human milk, and also that's for the refrigerated section. But the frozen line, my understanding is that depending on the milk bank that your hospital is working with, and we're just considering that we're talking about pasteurized donor human milk, frozen pasteurized donor human milk, that the hospitals that you're working with will fill the order based partly on how much turnover that your institution has. So if you order a lot of milk regularly, they may send you closer dated milk, what they call short dated milk, that's expiring sooner, because they know that you're going to use it before it expires. If you're a small community hospital that doesn't order very often and hangs on to milk for a long time, they're going to generally prioritize sending you milk that is going to expire later. But I think you bring up a good point that this is part of the practice, maybe as much as policy, that depending on who is ordering and receiving and stocking your inventory, that inventory should be set up in your freezer where the soonest expiration dates should be used first, so that you are protecting your investment in the purchase of pasteurized donor human milk. And I would just encourage everyone to be in, close touch with the milk bank that you're working with. I think everyone on the call probably knows we don't have a milk bank in Georgia currently, and that our NICUs have their needs met by other milk banks in the country. And so, having that relationship with the milk banks that you're ordering from, and making sure that whoever's checking in the milk has that training and expertise to sort the milk based on the expiration date.
Claire, there's a question in the chat. 96 hours in the fridge for the pasteurized donor human milk once the seal is broken.
So this is where I'm saying I think it would be helpful to have it all. But yes, I think it could refer to it being thawed, and it could be referred to once a seal is broken. I would refer individual hospitals to the milk bank that they order from for specific questions to guide their policy, and then also recommend that you have the book handy. So I can spend some more time with the book to see if there's further there. What I was going to point out is that there is whole sections in the book in addition to this chart, so that are cited and referenced. So when we get to the Q&A, I can spend some time. We can look at the actual book to see if there's further guidance around that last section on pasteurized donor human milk.
There's another question. Are you ready?
Yeah.
Are you wanted to? Okay.
Well, I'll hear it, and
so
then we might need to come back to it.
okay. Continuous feedings are then a real issue, if only good for 2 hours.
Yes.
So
Yeah, this has come
she
up a
anticipated
lot.
that one.
Yeah, this has come up a lot about continuous feedings and warming of milk and room temperature versus warmed. And I think this is an important topic for you all to consider in your interdisciplinary infant feeding team, committee, task force, work group that you have at your hospital. And if you don't have one, this would be a great topic to form one around, to ensure that you've got input from neonatologists, pediatricians, dietitians, lactation experts at your institution, to make sure that everyone has clarity about what standard you are setting in your policy, and know how to answer questions about it, and know what the references are. So I especially appreciated that these guidelines were identified as being appropriate for high-risk infants, because some of the other guidelines don't specify, and then it kind of begs the question about whether those guidelines apply to the NICU or immunosuppressed infants or very preterm infants. So I thought that was really helpful. Another area that's come up in our initiative is around consent and assent processes for pasteurized donor human milk and human milk derived products. There's an interesting section in the book, Best Practice for Expressing, Storing, and Handling Human Milk, about this topic that raises some questions for teams to consider around transitioning from obtaining written consent to verbal assent for pasteurized donor human milk. There's also a very helpful appendix that reviews education points for families that are being asked to consent to pasteurized donor human milk. And as this topic is very timely and may have legal implications, we encourage your team to also put this topic on the agenda for your interdisciplinary infant feeding committee to discuss. And as I mentioned, it's a good impetus to form one if you don't have one already at your institution. But whether you're doing assent or verbal consent rather than written consent, the parent's approval or agreement should be documented in the medical record, and it should be informed. And so I think it's important, this has come up in office hours and some of our site visits, that the folks that are consenting with parents are able to explain what pasteurized donor human milk is, how donors are screened, and how the milk is pasteurized. Not necessarily all the nitty-gritty, but that you have a clear understanding and are able to answer frequently asked questions from parents, because there's a lot of implications if a parent refuses to consent to donor human milk, especially for very preterm infants and others that may be at risk of necrotizing enterocolitis. The book recommends that physicians, nurses, advanced practice providers, and lactation consultants all be prepared to answer questions from parents about donor milk if you offer it in your facility, so that we can ensure informed consent. And the book has some great resources, as I mentioned in the appendix about this. I am going to, we can, I think, stop the recording and move to some more Q&A. We have another 10 minutes or so. Laura,